Hello, I'm Dr. Robert H. Gregg. I am the owner and founder of Millennium Dental Technologies and also the president of the Institute for Advanced Laser Dentistry, where we teach the LANAP, the LAPIP, and VAPS protocols. And may not be known to those who have not come through training that what we teach here is not just how to use a laser. We teach a multidisciplinary approach to a multifactorial problem that is periodontal disease, which is the destruction of soft and hard tissues in the bony housing around periodontally involved teeth. So it isn't just about filling a hole or scraping a root. There's much more that goes into the regenerative process of healing that I've dedicated the bulk of my professional career to understand and to resolve. So it isn't just sticking bone graft material in a hole or a biologic and expect for magical things to happen on a consistent basis. So what we have to do is to attend to all of the insults and the trauma, both infectious, inflammatory, noxious, as well as traumatic. And often cases, these are not altogether addressed during conventional periodontal treatment therapies, whether it be so-called non-surgical scaling and root planing or scalpel blade reflective surgery. So things are changing, dynamics are changing. In fact, I don't refer to periodontal disease so much as a disease as it is a syndrome of many facets of body breakdown, especially in the oral cavity. So one of the key components in what we teach in our LANAP training is you must attend to the trauma from the occlusion, the patient's bite scheme. Now, what does that mean? Well, we have found that the amount of bone loss is directly related to the amount of pounds per square inch of pressure applied to a given tooth. Wow, that sounds like it's engineering. Yeah, absolutely. We use engineering concepts in LANAP training. What's that got to do with the laser? Nothing, because this isn't about using a laser just in and of itself. This is about a protocol for regeneration where the laser is, the PeriLase MVP7, is the key critical device for activating stem cells, growth factors, upregulating gene expression, etc. But that isn't going to happen if you don't first and foremost address the trauma that's pounding on the bony housing. So what do we do? Well, as Dr. Pete Fetty used to say at University of Kansas City at Missouri, in our LANAP protocol, we grind the teeth low and let them grow. What does that mean? We're using the principles of forced super eruption, or in this case, passive eruption, because teeth that have a destruction in the bony housing, ligaments are separated, degraded, destroyed, and the bone is unstable. Teeth are mobile to some degree. So those teeth are not in a stable environment. They're going to need to move and rattle around. But in order to do that, you have to take away the opposing forces. So what we do is we grind the teeth, get them out of occlusion, and then they need to be allowed to super erupt if they want to. Sometimes they just reorient themselves in the bony housing. Well, one of the key things that we use in the protocol to do that is the Quicksplint. The Quicksplint provides a very quick and simple mechanism post-operatively when there's still some clotting blood and we really don't want to disturb the full mouth or the quadrants that we did by taking impressions at the time. Yeah, we could talk about taking impressions previously, but that's not always possible. That's not always practical. And the Quicksplint allows for us to have an immediate option to disocclude the patient's bite so that there's no trauma to the recently treated LANAP teeth or the LAPIP teeth. And that's something you would learn in training. Well, wait a minute, implants don't move. Well, you might be surprised what implants do dynamically and in disease. But that's not something I'm trying to get into right now. If you're trying to do the LANAP protocol and you're not addressing the occlusal scheme and the bite trauma aggressively, you're not really doing LANAP protocol. So we will step into the operatory and we will show you the Quicksplint quickly. So you'll see how efficient it is, and allows the patient to leave the operatory, go home, and have something that they can have, as we have often said in the past, leave the tissues in repose so the tissues can heal. Cells will not populate a root surface or anywhere in the diseased bony housing if there is any sort of trauma, moving the teeth around, microtrauma, macrotrauma. That's just how cells don't appreciate it. You wouldn't want to fix a broken leg and then let the patient walk on the broken leg. No, it makes no sense. You stabilize it, you splint it, you don't let the bone move. Well, in conventional periodontics, it doesn't seem to bother the periodontist that they're going to let the patients pound away on teeth and bone that have recently been surgerized. Makes no biologic, physiologic, or healing 101 sense at all. So let's go to the operatory and see how this clever device, simple is better. I love simple. I tell everybody, don't overcomplicate it, simplify it. Quicksplint is simplified, personified. Thank you. Okay, welcome to the clinic, my operatory and my private practice. The same operatory that I developed, the LANAP Protocol, some 30 years ago now, hard to believe. We're here with Lynn, who had half of her mouth treated with LANAP a week ago. How are you doing?
I'm fine.
You have any problems post-operatively other than the antibiotics? We're a little...
None whatsoever.
Little cranky. So we just finished the right half of the mouth, and we just finished the occlusal adjustment. And today was another comfortable procedure. Even though you're still numb, you will not likely have anything adverse to look forward to. So now that we've done the occlusal adjustment, and we want to account for those teeth in the posteriors especially, for super eruption and allow them to not be in any sort of contact, we're gonna, and we're not necessarily making her a full fabricated bite guard at this particular point in time. It would not necessarily be a good idea. As the bite scheme changes, as the teeth super erupt, we would be constantly making acrylic and or digital bite guards. Not necessary, especially when you have the Quicksplint technology. So I'm going to ask Veronica here, a longtime able assistant, to show you what the Quicksplint container looks like. Go ahead and open it up, and what we find inside is a nice little preform plastic container, if you will. Not too dissimilar from some other anterior disocclusion technologies where we're trying to keep the anterior teeth in contact to disocclude the posteriors. We also use this with patients with myofascial pain syndrome or TMJ pain to allow the masseters to relax and find the bite scheme that is perhaps being hidden prior to using the Quicksplint. So this is intended to be used for 1 to 2 weeks. However, we find patients will often use it much, much longer as a means to help relax their jaws or make their bite feel better if for some reason it's not feeling good some months later. So this tray, if you will, we'll put some polyvinyl siloxane in there and have the patient bite down, and then we'll trim it up and we're done. So let's go ahead and do the honors there. You can see how quick and simple and efficient this is. And the reason that Veronica is doing this is because I'm not allowed to get next to impression materials anymore. I lost that privilege after I left dental school. And we're just going to have her bite down in centric occlusion. There's no need to do anything else. And she's positioning it and aligning the anterior teeth in the middle of the tray. And she's biting down again in centric
There's really not any way you can mess this up. The whole point is to keep the anterior teeth disoccluding and also disoccluding the posterior teeth. And as quickly as polyvinyl siloxane sets up, this sets up, trim off any flash, and it's ready to go. Like the product says, it's quick. And doing this after the first half of the mouth that's done allows for the supereruption to take place that can be addressed on the second treating the opposite quads and addressing those teeth before you go on to treating and adjusting the bite on the second set of quadrants. And there you have it. Pretty straightforward. It's still setting up a little bit, a little tacky. It's flat on the opposite side, so there's no additional surface that needs to be included in the polyvinyl siloxane. This allows the patient to slide around and have freedom of movement, which also helps with relief of pain and muscle trismus or muscle spasm. We can go ahead and trim it up. Okay, so Veronica has trimmed this up and removed the excess and notched this out a little bit so that doesn't hang up on the incisal edges on the lower anteriors. And there you have it. And it's good to go. Just took a few minutes to trim it up and it's ready for prime time. Thank you very much.